Hello and welcome everyone. Today we'll be discussing about echocardiography guided management of the atrial fibrillation in critically ill. It is basically a practical framework how we can use echo to guide our atrial fibrillation management. Why does atrial fibrillation matter to us in the ICU? It does because it is pretty common, especially in septic patients, post-operative patients, patients who are having any kind of a shock. So the loss of this atrial kick and the irregular RR interval reduce the LV filling and the coronary perfusion. So this is the physiological framework to understand how actually my heart or my patient's heart is getting affected. That is how echo comes in and helps us personalize our decision in these patients. So how do we acquire the image in atrial fibrillation? First, do a beat averaging, average 5 to 10 beats, or use the index beat method with similar preceding RR intervals. Check the LA volume, avoid foreshortening, use biplane Simpson for the LA volume and index it to the body surface area. For high HR, you have a technique that is a trapezoid method for the A wave VTI when the EA fusion is occurring. And for documentation, record your heart rate and the vasoactive dosages you are using during this particular measurement. So, just a refresher on the pathophysiology. The hemodynamic is affected because there is a loss of the atrial kick, leading to a variable stroke volume and mean atrial pressure. Right ventricular failure or pulmonary hypertension, atrial contribution, and the rhythm regularity are disproportionately important. So, in these patients, the effect of atrial fibrillation is much more. The triggers of atrial fibrillation are catecholamines, hypoxia, pulmonary hypertension, fluid shifts, valvular disease, which act as triggers for this atrial fibrillation. So these are some code measurements to get our first answer. The LV systolic function, which we visualize or use the Simpson's method or MAPC or the S prime velocity. Then the filling pressure, this is a composite approach. The septal EE dashed more than 11 supports a high left atrial pressure. Right heart and pulmonary hypertension, again TAPC, SPAP for RV-PA coupling, and you also check the valves for the regurgitation and stenosis and if any prosthesis is present. Regarding the LA size and function, the LAVI, that is the chronicity marker, the left atrial volume index, it stratifies chronicity and the likelihood of rhythm maintenance. Then you have LAEF, that is left atrial ejection fraction, which is the recovery predictor, and after cardioversion predicts the mechanical recovery. Regarding AVTI, that is A wave VTI, it reflects the atrial contribution to the LV filling after the restoration of the sinus rhythm. Now there are some cutoffs. You can go through this. They help us in understanding through the values which method we should be using and what is the probable prognosis. So each has its interpretation. So you can take a screenshot and see what it means. Regarding the LV systolic function and safety, if the LV ejection fraction is more than 35, the broader antiarrhythmic options are available and safe for most agents. However, if the LV function is compromised, avoid myocardial depressions and amiodarone with or without digoxin is preferred. Depressed LV function magnifies the harm from tachycardia and the negative inotropy. So the left ventricular fraction, ejection fraction is critical to streamline our treatment management. Regarding the diastolic function, again you do the same things that you normally do, that is the E prime, LA size, pulmonary venous profiles, and restrictive filling reduce the success of rhythm strategies and tolerability of high heart rate. So in these patients probably you can go for a rate control. So pre-cardioversion optimization, optimize the afterload, the heart rate and the volume before attempting a cardioversion. So these things are very important. Next is the right heart and the pulmonary hypertension. Right ventricular dilatation and pulmonary hypertension associated with AF and instability, there is uncoupling of the TAPC and the systolic pulmonary artery pressure, and this raises the risk of tachycardia and hypotension. In this, the key strategy is a rhythm control when feasible, and choose the most less depressant drug. Regarding the valvular disease, if you have stenotic lesions, then there is a risk of thrombosis. The factors here more relate with rate control and anticoagulation. For regurgitant, again, the MR can increase the LA washout and cause problems for the patient. So the strategy again is important over here. Regarding prosthetic valves, again you have these anticoagulation needs, the risk of the emboli, and transesophageal echo is often needed before you can go for a DC cardioversion. Again, catecholamines which are used will have an impact on the atrial fibrillation as well as the return of the systolic function. So to uh, decide between whether I should go for a rhythm control or a rate control, first look for the ejection fraction. Assess which drug can be given safely and which cannot be given, and also the risk of cardioversion. Then the LAVI set the initial direction for the strategy. Next is the right ventricle and the pulmonary hypertension, the valves, which will refine your approach. And finally, post cardioversion check, where you look for the LAEF, the AVTI at 4 hours after the shock to confirm that there is a sustained improvement of the patient. So when do we prefer a rhythm control? The ideal patient would be someone who has a new onset atrial fibrillation in whom the LAVI is less than 40 and there are no valve diseases, and you do expect hemodynamic gain. So you will find an improvement in the systolic stroke volume, the MAP, and reduce in the catecholamine requirement. In the follow-up, look at the LAEF and AVTI at 4 hours. And in where will we prefer the rate control, where there is structural indicators, that is LAVI is more than 48 and there is restrictive mitral inflow. Valvular diseases will be better with lower heart rates. And you target a heart rate of around 100 to optimize the diastole and the oxygen supply. Revisit the rhythm attempts only if the physiology changes significantly. Do not randomly go without a change in the physiology. Regarding cardioversion, the DC cardioversion for instability or low cardiac output state, immediate intervention is required. Success factor is that it improves with appropriate pre-treatment and echo selection. Expect recurrences without adjunct therapies and physiological corrections. Regarding drug selection for echo phenotypes, where you have an ejection fraction of more than 35 and non-dilated LA, you can go with short-acting beta blockers. And for where the ejection fraction is less or you have a structural heart disease, it is always better to go for amiodarone with digoxin. Other agents can be tried. Regarding patients who have a right ventricular disorder, here again you prefer amiodarone. You can try beta blockers, short acting, but with caution. Regarding class 1C, only if there is a preservation of the left ventricular function and no structural disease, you can try that. You will need transesophageal echo guidance, especially for coagulation, if it is persisting for more than 24 hours and or if it is for unknown duration. And high risk markers are left atrial appendage emptying velocity less than 0.4 and dense spontaneous echo contrasts. For individualization, balance the CHA, the CHADVAS against bleeding coagulopathy and tailored to echo phenotype. So post cardioversion timeline 0 to 1 hour, stabilize, minimize the catecholamines, confirm there is a rhythm correction and reassess the ventilation. At 4 hours, check the LAEF and the AVTI. If you get reassuring, then continue the rhythm strategy. If low pivot, go to rate control. And 24 to 48 hours, brief rescan if recurrence or hemodynamic drifts are occurring. Hemodynamic effects after the sinus rhythm restoration, the heart rate decreases and you get a regular rhythm. Stroke volume will rise with the atrial crick restored. Cardiac output will decrease despite the higher SV because the heart rate is now low. Vascular resistance will show a rise with improvement in the MAP. Typical results are vasopressor dose is reduced once the sinus rhythm is achieved. Regarding sepsis patients with new onset atrial fibrillation, a rapid echo, assess the functions, strategize the treatment that you will give, choose your drugs, and go for cardioversion if required. Regarding the patients who have pulmonary hypertension, atrial fibrillation will worsen outcomes, and sinus rhythm is very important. And in this, ventilation strategy is very important. So, PEEP, tidal volume, and prone ventilation should be tried. Drug strategy favor rhythm control more and minimize the negative inotropic impact. So there are some pitfalls with the measurements. A single beat left ventricular ejection fraction is inaccurate in atrial fibrillation. So always use a multi-beat averaging. Regarding the LAR underestimation, as we have already told, foreshortening is common. Try to avoid with the apical planes. Vasoactive changes unrecorded between scans. Log the doses with measurement, which is very important. So coming to a practical bedside decision chart. First, check the left ventricular ejection fraction. Next, check the LAV1 to set the direction, in which direction you want to go, the rhythm or the rate. Then check whether the patient has a valve disorder or a right ventricular disorder. And finally, post cardioversion, check the effect on the physiology. What remains uncertain is that the LAEF and the AVTI thresholds across different pathologies and ventilator settings is unknown. Optimal drug sequencing is not known. We don't know how to sequence it if there is a mixed dysfunction. Prospective ICU trials stratifying by diastolic stage and LA mechanisms is not yet done. So the take home message is do a echo upfront to personalize the rate and rhythm decision. Do these measurements and determine which direction you want to go to. Check what more you can do, and finally the anticoagulation.